This is a presentation on the diagnosis of ADHD, and you'll get more of the management and monitoring of these children when you do your chronic illness course. But this is for the well child visit where they mention some concerns, and you want to do some initial screening and diagnosis. I'd like to thank nurse practitioner Joanne Hopkins and the physician Doris Greenberg for sharing some of the information in this presentation at a previous NAPNAP conference. As we talk about attention deficit hyperactivity disorder, there is a historical context which I think is important for us to remember. And this little poem was actually written in the 1800s. And it's about Phil, and Phil's supposed to stop acting like a worm. The table's no place to squirm. Thus speaks the father to his son, severely says it not in fun. Mother frowns and looks around, although she does not make a sound. But Philip will not take advice. He'll have his way at any price. He turns and churns, he wiggles and jiggles, here and there on the chair. Phil, though, twists I cannot bear. And so it clearly is describing a child with ADHD, even in the 1800s. Also, there was a piece that was discovered on attention deficit without the hyperactivity. And this comes from Weiss and Weiss Attention Deficit Hyperactivity Disorder, published in Child and Adolescent Psychiatry. Jane was dreaming, looked spaced out, which made her teacher want to shout, "Pay attention, start right now, keep your mind on task somehow. You knew your spelling words last night, and yet today there are none right. Your attention flits to every sound, homework lost and never found. Your books are always out of place. Jane, these are problems you must face." So those are two little pieces of literature that sort of exemplify the difference between children with ADD and ADHD. We have learned a lot in the last decade or so about the molecular genetics of ADHD, and we have actually identified specific genes that are associated with ADHD. There's the dopamine receptor D4 gene, the dopamine transporter gene on chromosome 5, the D2 dopamine receptor gene, and the dopamine beta hydroxylase gene. And there are several genes involved, and their effects are cumulative. So we know a lot more than we once did about this condition. There have also been some fascinating studies on the neuroimaging in ADHD, and this particular slide shows an fMRI shows decreased blood flow to the anterior cingulate and increased flow in the frontal striatum in those kids with a normal control fMRI in the brain and an ADHD child. And then other studies with PET imaging show decreased cerebral metabolism in the brain, in the areas of the brain that control attention. And then some additional studies on SPECT imaging, or using SPECT imaging, show increased DAT protein binding. So we know that this is not just the kid's choice. This is actual differences in their brain that make these behaviors and the inattentiveness and the hyperactivity occur in these children. The studies have also indicated some very interesting areas of impairment, which are sort of collectively presented here in this slide. And as you look at the child with ADHD and you look at their, at 12 o'clock, if we look at this circle, academic limitations are obvious, usually early on with the school-age child. And then relationships, and sometimes relationships and academic limitations are noted simultaneously or one before the other. Those two things then usually lead to low self-esteem. The impulsivity can lead to injuries. As these children reach adolescence, they become more and more aware that they're different, and they begin to self-medicate with smoking and substance abuse. Again, the impulsivity along with the substance use leads to more motor vehicle accidents and legal difficulties. And then as they reach adulthood, occupational and vocational problems can develop as well. So as we look at this circle of potential problems, so because of the potential areas of impairment, it's critically important that these children be identified, diagnosed, and helped early on in this process. And some recent literature really looks at how not treating these children is critically important for us to examine, because they end up with far more health problems, far more legal problems, far more interpersonal problems if they're left untreated. So let's talk about some of the screening tools that are available to help you in your well child setting. If the parent says either they've noticed some behaviors that are concerning, and or the teacher has reported some concerns. So one of the standardized instruments that's available for you is the Vanderbilt Assessment Scale, and it should be completed by both the parent and the teacher. And you can access it on the website at myadhd.com. And what we ask the parent and the teacher to do is to rate the child. And when you're completing it, think about the child's behavior in the last 6 months, and specify was the child on medication or not taking it or not sure. And as you can see, it goes through a series of questions that asks about the child's paying close attention to details, having difficulty keeping their attention, doesn't listen when spoken to, doesn't follow through on instructions, has difficulty organizing tasks, and he can read through the variety of behaviors that it quizzes the parent and the teacher on. And then it's scored, and it actually can help sort out this is a good screening for sorting out ADHD that's predominantly hyperactivity and impulsive type, ADHD that's a combination, and also oppositional defiant screen, conduct disorder screen, and an anxiety depression screen. So it gives you a lot of information that helps with sort of which direction you want to steer the family for additional assistance. Other instruments that are also validated and can be used, the Conners rating scale. There's also a parent and a teacher version, and really the diagnosis of ADHD requires that these behaviors are present in more than one setting. And this has both a long version, which has 80 items, or a short version that has 27 items, which are a subset, and has also the subscales similar to the Vanderbilt that also help with identifying oppositional defiant cognitive problems and an attention hyperactivity, an anxious or shy child, social problems, psychosomatic. And then there's also the SCAMP, which is an actual impairment assessment, the child depression inventory, and the child behavior checklist. And these are all validated instruments that can help you with the screening. And most practices sort of assess what all is there and what's the best fit for their population, and have those available for assessment if a concern is raised at the well child visit. So here is the SCAMP, assessment of impairment, and you can see that there are 10 questions and they're rated not at all to very much. And there are things like difficulty getting started on classroom assignment, difficulty staying on task for a class period, problems in interactions with peers in the classroom, problems in interactions with staff, either the teacher or the aide, difficulty remaining quiet according to classroom rules, and so on. So it just gives you a little taste of what the questions are actually assessing. The continuous performance assessments can also be used, and the integrated visual and auditory, the TOVA, which is a test of variables of attention, and you also have the essential components of your evaluation of children. So let's say the kid comes in for a school-age well child, and you get from the you get from the chief complaint that day, or any concerns the family has, that the teacher has reported some concern about this child's behavior and in class. And so you're going to start this interview with their birth history, their health history, any family history of problems with certain medications, any current medications for this child's developmental and behavioral history, the family medical history, which needs to include psychological history, and really be tuned into things like conduct disorders and attention deficit or impulsivity and frequent accidents. All of that sort of stuff is really significant when we're evaluating these children. Certainly a past history of head injuries in this child we know makes them more susceptible to ADHD. Any family stressors, which might make this more anxiety or conduct disorder versus ADHD, and any prior ADHD or psych diagnoses, how it was treated and how the child responded to the treatment is essential. So the DSM-5 criteria changed just a little bit how we diagnose ADHD. And for the kids under 16 years of age, there are supposed to be 6 or more symptoms of inattention. And for the adolescents, it's 5 or more. So the bullets present the criteria for you. And again, you're going to want to use a validated instrument to help with the diagnosis. But these are the criteria. And so a child often fails to give close attention to details or makes careless mistakes in schoolwork, at work, or with other activities. Often has trouble holding attention on task or play activities. Often does not seem to listen when spoken to directly. Often does not follow through on instructions and fails to finish schoolwork, chores, or duties in the workplace. For example, they lose focus or get sidetracked. Often has trouble organizing tasks and activities, often avoids, dislikes, or is reluctant to do tasks that require mental effort over a long period of time, such as schoolwork or homework. Often loses things necessary for tasks and activities, school materials, pencils, books, tools, wallets, keys, paperwork, eyeglasses, mobile phones. Those things are often misplaced. Is often easily distracted and is often forgetful in daily activities. So it's a number of potential issues, and the child up to 16 needs to have 6 or more of the symptoms. We've noticed over time that as children mature, these issues become less prevalent, less obvious, and so it's 5 or more for adolescents. So the hyperactivity and impulsivity are 6 or more symptoms for children up to age 16, and 5 or more for adolescents, just like the previous. And the bullets represent the criteria here for the hyperactivity and impulsivity. So fidgeting with or tapping hands or feet, squirms in seat, often leave seat in situations when remaining seated is expected. So frequent trips to the pencil sharpener, frequent trips to the bathroom, frequent trips to the water fountain. These kids often run or climb in situations where it's not appropriate. They're unable to play or take part in leisure activities. Taking turns is really hard for them. Is often on the go, acting if driven by a motor, talks excessively, blurts out an answer before the question's been completed, has trouble waiting turn, and interrupts or intrudes on others, butts into conversations or games. In addition, the following conditions must be met. And so they may have several inattentive or hyperactive impulsive symptoms present before the age of 12. And they need several symptoms present in 2 or more settings, which we've already mentioned. There's clear evidence that the symptoms interfere with or reduce the quality of either their social interactions, their school, or their work functioning. And the symptoms don't happen only during the course of schizophrenia or another psychotic disorder. So the symptoms are not better explained by another mental disorder like a mood disorder, anxiety disorder, dissociative disorder, or personality disorder. So these DSM-5 subtypes are depicted for you here on the slide. And ADHD predominantly is the inattentive type, and the criteria met for the inattention, but not for the impulsivity or hyperactivity. This type tends to occur more in girls, and unfortunately has a more significant learning disability component with it. The impulsivity hyperactivity combination is more the impulsivity type, and the criteria need to be met for the impulsivity hyperactivity, but not for the inattention. And then there's the combination type, which is our last 2 bubbles, and the criteria need to be met for both. So children can have one of 3 types. The domains of impairment are listed for you here, and as I mentioned, the data from the research clearly indicate now that there's several domains of impairment, and the impact of this disease is so great as the child progresses that we're far more aggressive in treatment. So these children should be referred for further assessment, for educational plans, and for medication, as well as the behavioral plan. So we know that the academic impairment occurs, the self-esteem, the social, the criminality, sexual behavior can be very impulsive, substance abuse, and health and injury are very impacted for these children. We also know that ADHD affects their socialization. Children are stigmatized by their behavior. Their behavior is disruptive, and it comes across as immature and impulsive, and that in adolescence continues to impact social problems, so they have poor participation in group, fewer friends, and they're really vulnerable to antisocial groups and drug abuse. And so it's critically important these kids be appropriately diagnosed and treated. As I mentioned at the beginning, the management of ADHD will be discussed in your chronic illness course, and the annual evaluation at each well child visit will be monitored to see how the child is progressing and adjustments made as necessary. Treatment involves medication, behavior management, and school management, and it's critical that all of these be addressed.